Well, thank you very much, and hello to everybody that's joining us this evening. Good day. I have been involved in rural nursing for about the past 12 years or so throughout my nursing career, and I've spent about half my life in Alaska and half my life in Montana, and kind of just by nature of wanting to live out in the Wop Wops, I've been the guinea pig for several different rural health programs and have found myself at the frontier of the use of telemedicine throughout my nursing career. I started out with a bachelor's in science and then went on to my master's of science in nursing, becoming a family nurse practitioner in 2006. And my first position was kind of baptism by fire into the practice. I worked for the Medevac Health Corporation up in Arctic Alaska, where I practiced full spectrum family practice. And in addition to patient care, I worked and had the privilege of being the chief of village services for that region as a community health aid instructor. And I'll get an opportunity to tell you a little bit more about that really special and exciting program. I then transitioned back to Montana, where I like to say that my children are fifth generation from, and started a new program as a hospitalist at our local critical access hospital that shares, I think, probably a lot of similarities with a lot of other rural healthcare delivery systems that maybe you all are familiar with. So I'd be really excited tonight. I am excited to hear about everyone else's experiences. I was honored to be able to come and speak with you tonight from a learning perspective for myself, to hear what kinds of things everyone else is doing and what kinds of resources everyone else is using. I just shared with Rhonda that today I was this afternoon at a meeting for several hours with our county commissioners here locally, because even though we have this great big beautiful hospital, we don't have enough volunteers to staff our ambulance service here in Libby, Montana, which used to be a volunteer-based service and still is, but as needs go up and volunteerism goes down, we have to look at different structures to make things work. So I'm excited to hear what everyone else is doing. But first I want to share with you a little bit about my background. So this slide tries to show a bit about the size of the area I was practicing in. The state of Alaska is, as you can see on the top there, it actually stretches about the entire width, if you use the Aleutian chains out on the west, of the entire United States. And what's highlighted in red is the Northwest Arctic Borough. So that's where I practiced out of. It's about 800 kilometers to the nearest road system. So we were accessing that area by bush plane and by jet, and about 200 kilometers above the Arctic Circle. So it was truly the land of the midnight sun. In the winter time, we would see a bit of a glow over the horizon, but we sometimes didn't see the sun. And in the summertime, we enjoyed sunlight throughout the day. I contrasted it down below to New Zealand. So the whole state of Alaska is about 1.72 million square kilometers. And in contrast, New Zealand's about 269,000 square kilometers. The Northwest Arctic, that area that I was practicing in up north, is really kind of similar in size to your guys' North Island. So it's close to about 113 square kilometers. Population density is a little bit different though, and that's the one thing I couldn't convert into kilometers for everyone, or square kilometers, but we have a population in the Northwest Arctic of about 7,700 people. And so it's pretty sparsely populated at 0.2 people per square mile. By comparison, there in New Zealand, the population density is 46.4 per square mile. So it's a pretty rural place. 80% of the people that live in the Northwest Arctic are the Alaska Native Inupiaq tribe. And there's a large portion of children in that population. About 35% of the population is under 18 years old. And this area really shares a rich cultural history dating back about 10,000 years. They've dated traveling groups that stayed in that area. It's a very highly subsistence-based culture. And the Northwest Arctic has the second highest annual harvest by weight per person of traditional foods, and that of course changes village to village. There are a lot of health risks that we were dealing with in the Northwest Arctic. 35% of the children that live in the Northwest Arctic are living in poverty, and 23% of residents report food insecurity. Severe housing problems affect 56% of the population, and that stems largely from just the fact that it's so remote. To get building supplies there to build housing is difficult. It's either by plane or by barge. It's very expensive. And a lot of the housing that's available is government funded or government subsidized housing. It's difficult to find those funds, so your family size per home is closer to 16 people or so living in each dwelling. 43% of teens and young adults aged 16 to 24 are neither working nor in school. There are public schools available in each village, but that would just go through high school, and there aren't many local options for secondary education there. Northwest Arctic teen birth rates are 5 times higher than the rest of the U.S. Sexually transmitted infection rates are 8 times higher than the rest of the U.S. And unfortunately, while I was in Norvik and in the Northwest Arctic, we had the highest suicide rate in all of the nation. And regardless, or in spite of having that unfortunate designation, we had very limited resources. This area is about the size of Rhode Island, or like I said, your guys' North Island, and we had 1 behavioral health therapist for everyone in the region, even though we had the highest suicide rates. So there were really some challenges delivering care to this population, but it was structured, healthcare there was structured out of the hub city of Kotzebue, and that's what this picture shows. Is Kotzebue is the primary town where you could fly a combi jet into. You'll see on the bottom of the picture some kind of longer airstrip. So a combi jet is half cargo and half passengers, and those would fly in from Anchorage, which is 885 kilometers away. And twice a day, there'd be a plane that came in, depending on weather, usually twice a day anyways. And healthcare in this region is provided by federally funded Indian Health Services. And so that federal program partnered with the local Native Medevac Corporation. Instead of developing reservations the way that most of the rest of the lower 48, as we call it, or the rest of the United States did in Alaska, it was it was structured a bit differently, and each different tribe had a for-profit and not-profit part of a corporation, and we had the Medevac Corporation locally. The hospital was based here in Kotzebue. There were not surgical services at the hospital. They did just get a CT scan about 6 years ago, right as I was leaving. But this primary hub hospital did have 4 or 5 local physicians that usually were there full time. And then in order to meet the rest of their needs, kind of a constant flow of locum tenens physicians, so providers that would come in and stay for a week or a month or a couple of months and then come and go. The ANMC is the Alaska Native Medical Center, and that was part of the Indian Health Services. So in Anchorage, 885 miles away, we had ANMC, or the Alaska Native Medical Center, and based out of that facility were various specialists, your cardiologists, your orthopedic surgeons, all your different specialties, and a lot of those would develop programs where they would come up to Kotzebue once a month or so. Things like colonoscopies and EGDs, they did some of those when they would bring the surgeons up about once a month or so. So outside of Kotzebue, this map shows Kotzebue there kind of on the little spit at the end in the middle, and this were the 11 surrounding villages for the Northwest Arctic Borough. And I was stationed in Norvik, so that was the first village up the Kobuk River away from Kotzebue. People usually went by bush plane from these villages back and forth to the hub city of Kotzebue, also sometimes by snowgo in the wintertime, by boat in the summertime, sometimes by dog sled. I did one time have to go from Selawik to Norvik by dog sled. Point Hope was our most northern village, and that's about 250 kilometers by air away from Kotzebue. And then Kobuk up at the end of the river there is another 250 kilometers away. So really out in these villages, I think it's similar to some of the island living, that some of the same kinds of challenges that you see where, again, everything has to be flown in or barged in, and that can lead to a really high cost of living. When I was living there, a gallon of milk down in what we call the lower 48 or the rest of the United States probably cost $2 or $3. And there in the village, it cost closer to $16 because that was all being flown in or barged in. Same thing as gasoline, very, heavily reliant on gas for your snow machines, for your boats, for all of your transportation needs. About $2 or so a gallon down in the States, and about $8 or more a gallon up there. So if,
sorry, Michelle, with that, just out of interest really, with that that high cost of bringing goods in, what sort of things do the locals rely on for, like local produce or access to, food and things?
Right. Well, like I said initially, it is a very highly subsistence-based culture. And so your food sources, because of the cost and because of that being what everyone is used to, was primarily subsistence-based food, even for us. So caribou, where we were at in Norvik, we were inland a little bit. So we were caribou and moose. A lot of water in the area. You can see most of the villages are situated along either the coast or the river, so quite a bit of fish. She-fish are similar to a tarpon, smaller whitefish, salmon, pike, sea lick. There were lots of fish-based diet. There were berries in the summertime, so blueberries and ockpicks and some greens that were locally harvested, but not a lot of produce. So the coastal villages for beluga whale was big, humpback whale, seal, and walrus. My daughter grew up teething on muktuk, which is whale skin with then a bit of whale blubber. And then we would dip that in seal oil, so rendered seal fat. And all of that's very high in vitamin D. And one of the cool things about bringing subsistence foods to patients is in Kotzebue, where the main hospital is, they started a program. And as you can imagine, some of those kinds of foods like rendered seal fat, it could be difficult to market to everyone, but to even be able to serve in a hospital presented some problems because of some of the health-borne risks associated with that. But they did get a program set up in Kotzebue so that their local hospital could serve those traditional foods, or we called it Nikipak, and they could serve Nikipak to their to the elders that were in the hospital there, or anyone else who wanted to be served those foods. So you had to go ahead.
Sorry. How do people communicate across that region being so remote? Is there access to cell phones? Is there coverage?
Cell phones showed up about 6 years ago. And prior to that, and something I'll talk about too is the radio-based system. So each town had CB radios that turned to a different station. So Norvik was channel 69 and Selawik was channel 72. And you could find elders sharing words. You could find Johnny telling Annie to please bring milk home from the store. You could find reports on the weather. You could find reports on where the animals were moving. You could find all of the village news on the radio system. So we used...
Sounds like our local supermarket.
Exactly. And we used radio traffic for healthcare that I'll talk about, which is exactly that, based off of the radios where you would call in from one village back to Kotzebue initially over a radio, some of your patient care needs, and help to structure healthcare that way. So this is an example of what one of those towns looks like. This is Norvik, and this is where I lived for about 5 or 6 years. The population is around 800 people or so, and it lies on the Kobuk River there. And as I mentioned, it's a river and inland-based subsistence town. So caribou, or tutu, is the Nupiaq word for caribou, moose, brown and black bears, beaver, whitefish, sheefish, salmon. One of my favorite stories about beaver was that I had an elderly woman that I was helping with an acute diverticulitis. And we did a lot of patient and family education on a clear liquid diet and trying to help her with that. And that night I got a call into the home, and I would do home visits for the elders. And she was in worsening pain, and I needed to go assess her. And when I got there, everybody was eating dinner, including her, and it was beaver tail soup. So we had to again revisit clear liquids, and that beaver tail didn't qualify. But you can see that the towns are very structured because all of the water, all of the sewer, all of the electric is all above ground. And the houses are built on stilts because of the permafrost underneath the ground there, and that causes quite a bit of shifting. So there's not really an urban area to these towns. When you come to town, you've got your airstrip as your lifeline to the outside world, as well as the river being that for transportation of goods and for yourself. And then everything else is pretty grid-like to accommodate. This is another example. Even within the Northwest Arctic, there's a lot of variance between each village. The culture in each village, of course, is different. This is a Kivalina, one of the smaller we call them barrier reef islands. And the population in the village of Kivalina is about 375 people. And you can see down at the bottom of the picture where they're kind of trying to construct a bit of a barrier wall there, because the rising sea levels and coastal erosion has really threatened the existence of this entire village. This village does, because of being where it's at, lack basic plumbing. So this village still uses honey buckets, or 5-gallon buckets, for human waste disposal. And the people here have a different subsistence base, usually beluga, humpback whales, seals or ugruk, walrus, salmon, and polar bears, or nanook, are more common out in Kivalina. While I was in Norvik, we actually did have the first polar bears in recorded history or verbal history that anybody in Norvik could remember. We had the first polar bears make their way inland to Norvik. They were eating out of the dumpsters that were about 20 yards away from where I was working and where I was walking to in the dark in the middle of the winter. So it was a little bit intimidating, but that had been a first. And so again, with climate change, we've seen some changes in those animal behaviors. They also saw the first walrus make its way up the river to Norvik, and that hadn't happened before. But this is the example of the clinic that I worked at. The dumpsters that the polar bear was visiting were just on the other side of this building. And this is a pretty typical village clinic. So outside of Kotzebue, each 11 of those villages has a clinic. And rural health clinics tended to really kind of be a hub for the entire community. While I was there, we served as a veterinarian. The clinic is also the morgue. The clinic serves as wellness promotion in the community. I know one time I needed the assistance of law enforcement, and we don't have local law enforcement in these villages, but we do have a designated village police safety officer. And when I put out a call on the radio on channel 69 asking for some assistance, the reply that I got when I asked for help was the phone number to the clinic. And I said, no, that's the phone number to me. I need someone else. So really kind of the clinic serves a lot of functions in these communities. And unique to Alaska, and something that I was so fortunate to be involved with, is the community health aid program. So out in these little villages, I was the only provider that was based in a village, and my position has not been filled since I left. But for 50 years, these villages, actually over 170 villages in Alaska, are serviced by over 550 community health aides. And community health aides are people that are local to the community, and they go through training to provide basic healthcare services. They're amazing, amazing people, as are many of us involved in rural health, because by nature of where they're on call 24 hours a day, 7 days a week, 365 days a year. They are treating their family members. They're called upon to do a lot for their communities. This is the basis for that community health aid program. So somebody will go into training camps. There are 4 or 5 different training centers around the state, and somebody will leave the village for 3 or 4 weeks at a time and go through a training. I think there are 4 levels of training currently. There are both primary care health aides as well as dental health aides. So there are dental health aides out in the village as well. And the basis of the practice is this health aid manual, or the CHAM. And the way that that works is if somebody comes in with a cough, you open to page 62 and you start following an algorithm of questions that have to do with that cough. And based on your level of training, at the end of that algorithm, you may be actually dispensing an antibiotic. So nowhere else in the United States are people dispensing medications without having a medical license. But the state of Alaska has had this very successful program in operation for over 50 years. So it's a unique version of healthcare, and I think it's an exciting thing to think about for how that could help other areas in the United States and around the world, because they've had a lot of success. Largely, that success has been related to just the people themselves, the community health aides, these amazing people that give of themselves for their community. But telemedicine has also played an increasing role in delivering that care. So this is an example of a telemedicine cart that would be typical to find in any one of these villages. And again, these are through Indian Health Services government-funded machines. They have I have a list up there of some of the various functions that they have on them. So they can do kind of live time transmissions of things like EKGs. They do have even a stethoscope that you can listen to, and someone at a distance. So whether that's a primary care provider that's in Kotzebue, whether that's a specialist that's at the Alaska Native Medical Center in Alaska and down in Anchorage, you can use this just as a real-time live camera as well. We used a lot of store and forward type pictures for skin disease, for dermatology. We used a lot of ear disease for young kids, using the tympanometer just to take a picture of the eardrum, send that on. They had spirometry available, and really, they didn't get used as often as they maybe could have, because so much of what we were doing was just face-to-face communication and developing relationships with other people. But they were available in each regional clinic. And then the other important part of rural care out in Alaska, of course, was our Medevac service. And we did use a fixed wing service. It was usually too cold for helicopters, and so we used fixed wings. They would fly up until about -28, about 28 degrees Celsius below zero. They would fly, and then when it was colder than that, they would not. So we didn't always have access to our medevacs, but we often prayed that we did. And in addition to our air medevacs, the community health aides are also first responders. So those calls would come across the radio that there had been a snow machine accident, or that there had been a trauma out in the field, and it was the community health aides that were also responding to those kinds of situations. This was just an example of a sled behind a snow machine trying to get out to somebody and get them collected up and brought back into the little clinic to be further assessed there. So I did this up in this kind of practice up in Alaska for about 5 years, but myself included, being on call 24 hours a day, 7 days a week, even when we would take the boat and go up the river for 100 miles or so, the radios still went with you and you still were on call. So after a while, I came back to Montana and changed my practice around. I'm sorry that this picture quality is not great, but I came back to Libby, Montana, which is kind of similar. It's got mountains in the background and it's got a river that runs through it. The population's a little bit bigger. It's 2,600 people here in town, about 10,000 people or so in the service area. 96% Caucasian with a median age of 46 years old. 27% of the population is 65 and older. So it's really kind of an aging community. We used to be a community here in Libby of natural resources, logging, mining. There was a large dam put on the river, but that's all kind of fallen by the wayside. The lumber mill is closed. There's no more logging. Both of the local mines have closed. So we have kind of a retirement population, and we have the highest unemployment rate in all of Montana here in Libby currently at about 10%. Which puts about 20% of our population here in town living in poverty. You may have heard of Libby, also connected to an asbestos mine. The company W.R. Grace had a vermiculite mine here in Libby, and our Environmental Protection Agency, the EPA, which is our big government environmental agency here in the U.S., did declare Libby the first public health emergency because of some of the exposure that occurred here to asbestos fibers. So to provide healthcare in this type of a community down in the US, we're not a part of Indian Health Services, but we do require, because we're rural, some federal assistance to stay afloat. Currently, 41% of rural hospitals in the US are operating at a loss. And really this is because of a lot of different factors that we all share, but we have the lower patient volumes. We don't have high patient volumes. And because of that, there's lower funding levels, there's decreased hospital revenue, and there's lower physician employment pools to pull from. And for all of those factors, we are seeing a lot of closure of rural healthcare. We're seeing a lot of closure of rural hospitals in the US. If the current rate of closure of rural hospitals in the US continues right now, about 11.7 million patients are at risk of losing their access to health care. So it's a bit of a crisis for rural America. In addition to lack of access to the hospital facilities, we really lack access to physicians, to providers. Rural communities are estimated to have a shortage of about 45,000 doctors by 2020, which is a crisis that will affect over 90 million rural Americans. So part of what the government has done to respond to that is to create a special designation called a critical access hospital. And that is the hospital that we have here in Libby, is a critical access hospital. And critical access hospitals, they have to meet certain eligibility criteria. They have 25 or fewer acute inpatient beds. They have to be located a certain distance from other hospitals. So our hospital in Libby is 145 kilometers to the nearest hospital, and that's in Kalispell, Montana. And beyond that 145 kilometers, it's actually about 500 kilometers to the larger hospitals, to the level 1 hospitals. Those would be in Missoula or in Spokane. These kind of critical access hospitals do have to provide 24/7 emergency care services and maintain an average length of stay of 96 hours or less for acute care patients. So if a hospital in a rural place is able to meet those criteria, then they're able to have a different reimbursement structure than other larger hospitals. We can actually do a DRG reimbursement model here instead of a cost-based, or we get cost-based instead of DRG. So in a bigger hospital, if somebody comes in for a diagnosis of pneumonia, you get reimbursed a certain amount of money for how much it usually takes to treat pneumonia. But in our hospital, we're able to actually get reimbursed based on the actual cost that it takes to treat that individual patient, which has helped some of these rural hospitals stay open and stay afloat. But as I mentioned, there's a large struggle with just maintaining physicians to keep these hospitals open and operating. So I was going to tell you a bit about the program that I ended up being involved in, which was starting a nurse practitioner hospitalist program, which is a newer model. It's not seen in many places yet. But what we do is we use telemedicine to connect our local hospital here, Cabinet Peaks Medical Center, with a larger hub hospital, so the Kalispell Regional Medical Center, which is 145 kilometers away. So about 2015 or so, about 3 years ago, our local hospital was using locums physicians coming in to support their inpatient service. And for many reasons, that was not a sustainable model. It's very expensive and it's not great patient care when people are coming and going all of the time. So our community board of directors reached out to Kalispell Regional and they said, let's use a nurse practitioner, which was a new thing, but it was timely. The Institute of Medicine's landmark 2010 report, The Future of Nursing, had come out with recommendations to allow advanced practice registered nurses to practice really to the full extent of our education and licensure in order to increase access to and quality of care in the struggling healthcare system. So as a response to not having physician providers available, we looked at nurse practitioners and hospital-based care, and we saw that there was reduced length of stay, that there was improved hospital profit compared to physician hospitalists, and all of this without altering readmissions or mortality. So we implemented a program here in Libby, and on the side of your screen, you'll see a picture of Dr. Annie Robbins, and that's a physician based out of Kalispell, just about 90 miles away from here, so about an hour and a half drive on good roads. And I started about 3 years ago, and I worked over in Kalispell with Dr. Robbins and with her colleagues for about 6 months. And that was a really great time to develop collegial relationships, not only with her, but also with the cardiologists there, and with the GI specialists there, and with the neurologists, and with all of the specialists there. And so now I'm back here in Libby, so I'm 90 miles away. And what I do every day is I go into the hospital and pick up my panel of patients. Our census is usually about 8 to 10 patients or so. And while I'm providing on-site inpatient care, I have full-time support by Dr. Robbins, or sometimes a few other physicians as well that fill in. But I put up a picture of a cell phone and an iPad because that's pretty much all we use. And her and I have shared electronic medical records. So she has access to all the patients that are in the hospital, to their labs and to their objective data. And how it works on a logistical level is I come in the morning and I run my panel of patients with her. And I do that a lot by text. I just text her in room 202. We have a 64-year-old male, community-acquired pneumonia. He's on these antibiotics. This is how he's doing. It's about 2 or 3 sentences. And so I have her support, and also if things are beyond the capability of what we have at our facility, then she's already there, aware of the patient, can help use other resources if we need to pull in specialists there. Then I can consult with them a little bit more easily because I already have a relationship established with them. And then if need be, we can transfer them to Kalispell if their needs are greater than what we have available.
Michelle, what access to diagnostics do you have to support, the care provision? Do you use point of care testing, or do you have a laboratory?
Here at our hospital, we do have a full lab, and it has most things that we need, which is a contrast certainly to being in the Arctic. So in the Arctic, when we needed a lab, that was something that we were drawing ourselves and then putting on the plane, the twice-a-day bush planes that would come from the village back to Kotzebue, and there was a lab in Kotzebue that would run that. And so you're looking at a 1 or 2 day turnaround. The medevacs that would come into the Arctic, when they would come and pick up patients, they did have a handheld unit that had some point of care testing that they could do. But we didn't have that available to us in the village. Here at this hospital in Libby, and most of the rural hospitals do have some kind of lab coverage for lab services. We actually have a CT scanner, a 64-slice CT scanner, and we also have an MRI that's available at the hospital here in Libby. It is. We have ultrasound. So it just kind of depends on what tech is on for the day. So it's what we can do depends on what our staff has been trained to do, and that depends, of course, on who's on. But we have a lot of resources in our little hospital.
Great.
So the best resource, I think, that so far telemedicine has helped us develop, though, is, as I mentioned, just those relationships with referral providers and those relationships that now I have with my colleagues elsewhere. Otherwise, rural medicine can be a pretty isolated experience. And so being able to consult with who I need to consult with and have all of the support of various specialties has really made a big difference for rural care here. The relationship building is key, because a lot of our rural nursing unique challenges are shared, and having that structural collegial support of my peers has really been invaluable. So in summary for that program, I did recently complete my doctorate of nursing practice. And as part of that, I looked at a year's worth of data, because I had just started this job back in 2015, 2016, and wanted to see how we were doing. So I looked at a year's worth of information on length of stay, on mortality rates, on 30-day all-cause readmission rates, on our HCAHPS provider communication scores, which is just a federal scoring system looking at how providers are communicating with their patients. And then we looked at total cost. And I compared the nurse practitioners that were providing hospitalist services with telemedicine support with their off-site physicians. And I compared our model, this kind of new model of care that we had developed, I compared that to just the locums physicians that had previously been the healthcare providers here for our hospitalist program. And over a year's worth of data, there was no statistical difference between the care that the physicians gave and the care that a nurse practitioner with telemedicine support gave to our hospitalized patients. So we're hoping that this new model of care, which was about 40% of the cost of a locums physician, that we can use this as an example for and as a resource for other rural areas that are looking for ways to keep healthcare available in the hometowns of rural patients where they need it. So those have been kind of my two big experiences in rural nursing, both out in the Arctic village for about 5 years or so, and then the same here, developing this new hospitalist-based program here. And I don't have anything else to share on the slideshow, but I'm super curious what other people's experiences have been, and if anyone has any questions, I'd love to share more.
Oh, thank you, Michelle. There's some good feedback coming through with the outcomes that you've achieved. It's certainly quite impressive. I just wondered, are you the only nurse practitioner at the hospital, or are there other people that support you so that you can have days off?
Yes, thank you for asking. So I'm half of the hospitalist service, and my typical schedule is 7 days on and 7 days off. We have had difficulty filling that other half. I'm the only person that lives here locally. Over the past 3 years, they try to bring in nurse practitioners from Kalispell that come and just stay in our community for a week or so. But again, they're not living in their home community. They're sleeping in an extra room in the hospital while providing those services. And so nobody's really lasted very long. So they still fill in that half that I'm not there, a lot of times with locums physicians. So we're always looking for another nurse practitioner that would want to be the other half of that.
So just for the people that have tuned in earlier before the session started, we were talking about a local nursing school, and if you explain how that's working, and the hopes for the future with being able to train some local people which may be able to help support that service delivery.
Sure. So our local community college has developed a relationship with some of the larger state universities, and there are several rural towns in Montana that are developing undergraduate nursing programs and trying to get local people that are involved in nursing school, trying to be able to offer them the ability to have most of their nursing school experience in their rural town. So we currently have the first 4 or 5 students that are going through that program here. It is a 2-year nursing program, and in the States we have a 2-year associate degree nursing degree, and then we also have a 4-year bachelor degree. And so a lot of these students will get their, well, all of these students will get their associate's degree, which is a 2-year degree, and hopefully they'll be able to access then online programs to get their 4-year nursing degree, which then allows them access to be hospital-based nurses. Most of the time, the 2-year nurses are outpatient clinic-based nurses.
And what additional training on top of that did you do to get to the position that you're in as a nurse practitioner in hospital?
So I graduated initially with my bachelor's, so with the 4-year, the Bachelor's of Science nursing degree. I didn't practice as a bedside RN very much. I went straight through from my bachelor's to my master's program. So the master's was an additional 3 years. And I did work as a bedside nurse and as a charge nurse while I was in my master's program. And so when I graduated with my master's, I took a certification exam. And I did a family practice focus. There's also psychiatric focus. There's pediatric focus. There's internal medicine focus. But I did a family nurse practitioner master's program. And so that was 4 years of undergrad and 3 years of master's, so 7. And took my certification exam, practiced for those years in Alaska, and then just finished up my doctorate online. And that was probably a 2-year program, but I was also working and a single mom, and so it ended up being 5 years spread out, and that was entirely online for my doctorate. And so that would have been about a total of 9 years or so.
It's certainly very admirable, the amount of study that you've done, and the ability to provide such a great service for your community. And I think I know with my experience working rural, people really respond well with knowing the people that are caring for them each time they come in. There's that level of confidence that offers in comparison to local.
When I mentioned that my children are 5th generation from here, my grandmother came through. She went to nursing school on the GI Bill in World War II, and so she came to this town in 1948 as a nurse. And she worked here for about 30 years or so before she retired. So a lot of the patients that I'm caring for in the hospital now are people that, if they're my grandmother's generation, those are the people that maybe are passing. If they're my parents' generation, those are the people that maybe my grandmother helped to deliver back when there was one nurse in the entire hospital for all night long and they made $2 a night. She likes to tell me about that. So it does make a really big difference that instead of having a machine rolled into a patient's room with somebody that they don't know from a town that's not from here, having somebody that's from the community or that's involved and now living in the community, providing hands-on care while using that backup resource has been it's really been the crux of the success of this program.
You mentioned before about the algorithm that the community health aides use with, treating illness, and that leads to sort of prescribing. And Andrew's just asking how prescribing works in Libby, and I'm wondering, in your absence, are the nurses that are caring for patients in inpatient service, are they also prescribing nurses, or how does that work for you?
Thank you for asking that question. So 2 different systems. So up in Alaska with the community health aid system, I mentioned radio traffic. So a health aid is going through the algorithm, and at the end, there's potentially a prescription that's being given, those are always signed off by a licensing prescriber. And so that's that process of radio traffic. So it used to be that that would be called into somebody over radio once a day. And then that's kind of evolving. Now it's actually computer based. And as the health aides are going through and the algorithm and asking questions, that's all getting recorded and then it's getting forwarded to a provider. So I sat on that receiving end sometimes for the various villages. And that was intense because at that point it was being faxed across. So it was kind of a handwritten report, and it was constant. With 11 villages, you were constantly looking at somebody's piece of paper. So there was a prescribing doctor that would, or a provider, myself as a nurse practitioner, that would sign off on those prescriptions. It used to be that there was a pharmacy in each clinic where there, once or twice a week, there would be a shipment of the basic formulary of medications that were kept in each village. That was transitioning in the last 5 or 6 years as well to be telemedicine based, where they're more in like a machine, like you get a candy bar or a soda pop out of, where the medications would be dispensed by a pharmacist in Kotzebue. So out in the village, once the okay would go through, the pharmacist in Kotzebue pressed a button that would dispense the amoxicillin over in Norvik. So that was changing. Here in Libby, we always, if it's not, I'm a prescribing provider, and the people who replace me are also prescribing providers, but the nurses on the floor are not prescribing providers.
So there's not 24-hour cover for prescription needs, or do you just sort of anticipate what the requirements might be when you're not at work?
So I am on call 24 hours a day, the 7 days that I'm on. So if patient situation changes, I do come home at night, but I am on call. So if something changes and the nurse feels like there needs to be an intervention, then that's a phone call to me just with a verbal over the phone. And we have a staffed pharmacy there. It's not staffed at night, but they have a Pixis system in the hospital here, which is the same kind of deal. It's the machine that you punch in the codes and then it spits out the medicine that you need.
That's great.
Was that the question?
Yeah, it does. It sounds like you've got great access to technology to help support that care provision, which is a huge benefit for your rural community. I've got another question here. Someone wants to know if you'd like to come and work in New Zealand on the Coromandel. And MPs are nurse practitioners part of the model of care delivery within the inpatient unit as well, or just yourself? Is it registered nurses that care for patients in your absence?
Yes, so I'm the hospitalist provider for the service, and then there are probably 4 to 5 registered nurses that are on staff throughout the day and night. So, well, they have a day shift and then a night shift. And then we also have, in our hospital, we also have a physician that is providing care to the emergency department 24/7. So I have that support and backup also if I need it.
That's great. Does anyone else have any questions that they want to raise just by using that chat function on either the top or the bottom of your page? Wait for a couple of minutes there.
If there aren't any questions, if people wouldn't mind sharing a little bit about what they're doing and what their role is and kind of what if we have time, I'd love to hear.
Yeah. While we wait, I could share, and I think I've spoken maybe last time we spoke about my background coming from Central Otago, and it's a 24-bed rural hospital, and it's around 200 kilometres to the nearest base hospital, and obviously relying heavily on good roads, and we use ambulance transfers or helicopter transfers to get people out to high levels of care. But we have a high dependency unit as well, and the catchment covers close to 25,000 people. It's quite geographically dispersed across the region. Can take, up to an hour and a half or so away by road for people to get in. But it's certainly not as remote as what you're describing with the communities that you're providing. We don't have nurse practitioners yet within the model of care at the hospital that I worked at. We have rural medical specialists that are trained fellows, so specialists in rural generalist medicine, and link quite closely with our base hospital and the specialists there. The system is actually looking at enhancing its delivery of telemedicine and to improve access to specialists, so to prevent the need for people to travel long distances across the region, which is a real problem. People have to obviously take days off work to travel for a 10-minute appointment. So just to try and close that gap a little.
One of the things that we use a lot of telemedicine for that I didn't mention was our stroke patients. We had a lot of grant funding in the state because we're so rural and because stroke care is so time sensitive. We had some grant funding that came across, and we call them the stroke bot, but that is just the machine that you roll into the room, and all we have to do is press a button and turn it on, and our neurologist that's at our hub hospital, the 90 miles away, can drive the machine. And so he'll drive it around the room, and he'll zoom in on people's pupils, and he has full capability to do a very, very thorough neurological exam. And they've done a lot of research on that, and it's made a big difference in outcomes for stroke patients to have that immediate assessment by a neurologist who then can give our ER provider, or if it's an inpatient, can give me the feedback that they want to give us. And so that's been the stroke bot has been kind of the entrance into telemedicine, and now adding me as an on-site hospitalist has been a new addition. And then we also do bring in to our community locally, we try to bring in some specialists like once a month or so through we're trying to get that up and running, but it's not being fully utilized yet, but we're trying.
Yeah, small steps, and it's having the successes with some services that will make that difference. And,
right.
It's a culture shift almost, I think, with the use of technology, and I'm sure within the next sort of 10 years we're going to see a greater use of it. Certainly for these rural and remote communities, it's going to be a huge advantage in trying to get some equity of care delivery.
Yes. Yeah.
Oh, more questions. What have we got? Time is saying that they've got nurse-led clinics with no general practitioners, with GPs available across their 4 clinics. Jane is a clinical nurse specialist and provides an outreach chemotherapy service to their population of about 25,000, and they're about 90 kilometres away from a tertiary oncology centre. We're just trying to hook up a mic so that we can try and chat with the attendees. So Jane, with your outreach chemo service provision, do you liaise quite closely with oncologists in which region? Yep, Christchurch oncologists. And they come down once a fortnight for clinics. That's a really great service. And that's based from Ashburton. You're from Ashburton, weren't you, Jane? Yes. So you do a nurse-led chemotherapy service 3 days a week from Ashburton. That's great. So similarly at Dunstan and Central Otago, they have a chemotherapy service 3 days a week, and they're full days now, and that's in close liaison with Dunedin oncologists, and they review blood and so on, and they send up not the oncologist, but the pharmacy department in Dunedin will send up the chemotherapy, and it's all confirmed with the oncologist prior to delivery. Marie is a practice nurse for a solo general practice in South Canterbury and provides prime, and it's 40 minutes to the nearest base hospital. So Prime in New Zealand is the primary response in medical emergency service, and it's a trained program that people do to be able to provide that service. It sounds similar to, well, similar, I guess, in some ways to the community health aides that you have, but they are health professionals that are Prime accredited, I suppose, and they will, it's often nurses who are Prime competent, and they provide after hours cover for rural areas for medical emergencies. There's a review nationally occurring at the moment in New Zealand for the Prime service, particularly around funding for that.
And that would be like first response to emergencies that was happening, and
that's right, and any
after the ambulance, and
yeah, and as well as the incidental things that are happening that may not need to go to high level of care, so infections and so on, and lacerations. So there's a see and treat service as well. Marie's saying they don't cover after hours, just the daytime. So some are able to I guess there's a variation, because I am aware that there are some Prime cover after hours in our region. There is that. So question, what's the best technology to invest in to support telehealth?
So in my experience, as I said, we had all this really fancy equipment up in the Arctic that could do a lot, and that can be really helpful. But the most important thing were the relationships that you had built with your referral providers, the relationships you had built with the people that were helping to support you. And right now in my hospitalist-based practice, I use my cell phone 98% of the time. We even just have an iPad that I could potentially take to the bedside, and the physician that I'm working with could potentially have a face-to-face conversation with a patient, and we pull that out maybe only once or twice a year. Because the most important piece of technology really is that relationship that we already have built. So it's certainly different for each scenario, but in both practice locations, really just the relationships you have with people, and the best way to keep those relationships going would be the best way to help support telemedicine.
Absolutely, I agree with that. And Jane's agreeing totally with the relationship building as well. Her question for you is, how far do your patients have to go to receive cancer treatment?
We do have chemotherapy. We have an infusion center based out of our hospital here, and it is run by nurses in our hospital in conjunction with the pharmacist that we have at the hospital. And typically the oncologist who's at our hub center in Kalispell, they go, a lot of times if it's like in a weekly infusion, they'll have them come to Libby for 2 weeks and then Kalispell for 1 week. And so there is still some back and forth for them. But that was started about 10 years ago or so here, to try to be able to let people stay in the community for some of their infusions.
So what support is there available for people who do need to travel, like with the distance that's required? And
very little. We have one public transportation van that goes over in the morning and home on the afternoons 4 days out of 7. And that's a public transport van that's taking people to Walmart. It's taking people to any place that they want to go, including medical appointments. And so that's the only support really that as a community we have for patients that need to go over to Kalispell.
And for people who do need to go and have a stay, in an inpatient service at your base hospital, is there a provision to support families to be with them and be accommodated, or do they have to fund that themselves?
They have to fund that themselves. That's difficult. It was part of the discussion today because, as I had mentioned, if you were on earlier, I was speaking with the county commissioners today because our ambulance service that both responds to 911 calls, so it sounds like some of this Prime kinds of responses, as well as does our transports from facility to facility, has been volunteer based for the past forever here in this town. And there used to be up to 40 volunteers, and now it's down to about 15 volunteers. So we're really at a crisis where I'm currently telling hospitalized patients need to be transferred, but I don't have an ambulance to transfer you because we don't have the manpower in our community. So we're getting politicians involved to try to figure out what's going to happen next. Right now we're calling ambulances from Kalispell, so they have to drive 2 hours here, pick up the patient, and then turn around and drive 2 hours back. So it's not the fastest way to get people in and out. And unfortunately then, if it's a slightly more critical patient, we're utilizing air transport services. So we are calling the helicopters a lot more frequently than maybe we would have if we actually had a ground crew that was able to take them. And that's a much higher cost to the patient, of course.
So does the patient pay for any medical transfer costs, or is that a publicly funded?
It depends on what their insurance is. Okay. And so for patients that are 65 and older, they have access to Medicare in the United States. So that's a federally funded insurance product, and that usually will cover it. But if you're under 65, you don't have Medicare. And if you don't have good insurance, that's about a $30,000 bill.
That's just quite debilitating and massive, isn't it?
It is.
So, here in New Zealand, Marie's also just highlighted that we have similar issues with ambulance access in rural areas with the reliance on a volunteer service. It is a huge issue, and there are times where we have to escalate to use air transfer to get people, to a base hospital where they would have been quite suitable to go by road and ambulance. So that costs the system a lot more.
Yes, and in Alaska, so Medicare covers patients that are 65 and older. It's a federal insurance program, and then Medicaid covers certain income levels, and especially women and children that are under certain income levels. So the state of Alaska has the highest expenditure of Medicaid for just that reason, because of all the air transport that happens in that state.
Similar issues, just a different place. It's really great to hear all of the things that you're doing to improve access to your community and local population. It's quite admirable, and I think that there's been quite a few things that we can be learning from here in New Zealand. There's a question here regarding how pregnancy is managed, because here in New Zealand we rely heavily on midwives for care of women during pregnancy and birth. How's pregnancy and birthing managed?
Up in the Arctic in Alaska, we had 3 or 4 certified nurse midwives that practiced out of Kotzebue. And so I, as a family practice nurse practitioner, did all of their pregnancy care up until, I think we did 36 weeks. And of course, based on what your risk was and prior deliveries, that sort of thing. But at 36 weeks, usually we ship people out of the village. So you'd have to leave, and that was another reason why the Medicaid costs were so high. You'd have to leave the village. You could go as far as Kotzebue. Kotzebue, we did deliveries there, but no surgical capabilities. So any more complicated pregnancies would have to actually go down to Anchorage, which was the 850 kilometers away. And then you're just waiting in a hotel room. And you're separated from your family, and you're separated from all of your younger children. So it was certainly challenging there. Here in Libby, we have local family practice physicians that also provide OB care, and we actually currently have in our community 1 OBGYN. We don't always, but he's been here a couple of years now. So, and that's another area where we've utilized telemedicine. In addition to the stroke bot, we have utilized that telemedicine capacity for neonatology, because that's certainly a specialty we don't have here and something you need right away. And so they've just picked that up in the last 2 years as well, where we have a neonatologist that's always on call that we can do live time with during a delivery.
So Marie's just asking around how palliative care is managed. Do you have a hospice, or do community nurses, like district nurses, help provide that palliation?
Yeah, we do have, we call it hospice, and hospice is staffed by both nurses and then community volunteers. And that's currently based out of Kalispell, just logistically from an administrative perspective. So it kind of changes, and it's unfortunately, it's not utilized nearly as much as it could be, and it's not supported as much as it should be. But we do have in-home care. If somebody's on hospice services, they might get a nurse visit once a week. They might get a nurse visit 2 hours or so once a week. So it really isn't a lot, but at least it's somebody that's available by phone for family to talk to if they need to. And then we take patients in the hospital if the care, we take them for respite. So we will put patients in the hospitals to give their caregivers respite. And then also if their needs become too great that they can't be managed at home, then we keep them here. But currently palliative care is based out of Kalispell. So that makes it tricky to make it work really well for our community, because we don't have a point man really here, which is something that I wish was better than it is.
So end of life care, do families support loved ones to remain at home with that brief support, I suppose, given once or so a week?
Primarily, and then we also have one long-term care facility in the community, or a skilled nursing facilities, or a care center, we call them. And so that has probably 30 beds or so. Most of the time, those beds are given to elders that don't have that support at home, but they're not necessarily hospice. Most of the time, our hospice patients end up back at home.